Thank you for joining us. I'm John Martin, the Chief Medical Officer of Butterfly Network and a vascular surgeon. Tonight I have intimate knowledge of the subject from both sides of the needle. Lord knows I've inserted my share of IVs over my 30+ year career of almost all types. And I've had the misfortune of being a patient multiple times and candidly pretty sick. So IVs were part of my treatment. I must also confess I found ways to insert them in myself at some tough times at home. IVs clearly own a particularly unique place in medicine. There are more than 200 million times a year an IV is started in the United States alone. And there are few other things in medicine that I believe are so routine, yet so underappreciated as to the anguish they create in patients and healthcare workers alike. When we all think about it, when the order is created to start an IV and you go to the patient's bedside, please raise your hand if you don't jump for joy when you see a nice, juicy cephalic vein just above the wrist. And equally, if your heartbeat doesn't go up when you place that tourniquet on the arm and there's nothing visible at all. We've all felt these emotions, and all certainly have seen the look on our patients' faces as they watch us, look for signs of confidence, and that very special look we get when we miss and we say we have to try again. It's so painful for all of us. Even worse, when you miss multiple times and you have to say, well, I have to call in somebody else or the PIC team, or even worse, calling for me, the vascular surgeon, for a central line. IV access is critical to the success of so many of our treatments, yet it's fraught with misadventures and the source of significant complications. But it, like so many things in medicine, is ripe for technology to improve our performance. We're very lucky tonight to be joined by two experts who are absolute specialists in this particular field. They are going to lead us in the charge to discuss what changes can be made to make IV access more predictable, more successful, and more likely something that we no longer dread. I'm thrilled to introduce Judy Lajoie. How'd I do, Judy? Whose initials after her name, when you actually see them, are about as long as the alphabet. And I could go into actually a great discussion of her credentials, but they're quite impressive. And she's even a more impressive individual. And Sean Lau, he's a vascular access specialist in an acute care teaching hospital in Northern California. He's participated in the clinical management and the administration of vascular access service. He's also the president of the Bay Area Vascular Access Network. He actively works with many hospitals, locally, regionally, and nationally, providing education and workshops on topics such as ultrasound-guided IV insertion, a topic near to us tonight, PIC placement and CLAPSI prevention. I'm also joined on here with my colleagues, Mike Stone, who's an emergency room physician, internationally renowned ultrasound educator, and our head of education. And hopefully if she jumps in, Jill Coleman, a new addition to our team, a heart failure specialist, and our chief scientific and clinical officer. Let's look at our agenda. We're going to talk a little bit about something that's near and dear to all of our hearts right now, and that is the impact of COVID-19 on bedside care and what impact it's had on IV access. What is the challenge of venous access in today's COVID world? What benefits can new technology actually play in that? And in particular, how can ultrasound guidance make a difference in the way we start IVs? And something that's really kind of an interesting subject that has not changed much over the years, but there's a fair amount of controversy. And what are the rules around maintenance of lines once they're placed? I think it's a key goal, and I certainly thought about this when I was sick in the hospital, that what we'd love to get to is an IV is placed once with a single attempt, and it lasts throughout the entire hospitalization. I think that's ultimately our goal. So what is really the impact of COVID-19 in bedside care? And I'll open it up. Feel free to jump in. Judy, why don't you start and tell us what has it meant to you and what impact do you think it has? And I know we've got a number of experts here that can jump in and share their personal experience. And I know Mike came off a shift just last night that he could share with us.
Yeah, thanks, Dr. Martin. Appreciate that. So I think that COVID-19 has just augmented or highlighted the need for appropriate vascular access. We know before COVID even hit from articles by Dr. Helm that told us that on a good day, without a world of COVID, 90% of folks walking into a hospital get some type of vascular access. We know that 35 to 50% of those lines fail, and they cost anywhere from $28 to $35. So if you do the math on just that alone, right, in a non-COVID world, if I have a 200-bed hospital, I'm looking at $1 million impact, right, to failure. And a lot of people don't pay attention to that failure because they consider it a $1.50 item. That's, a commodity, if you will, but it really has some significant impact, not only to the patient outcome, right? So to your point before, we need a world that's one patient, one stick, one success, and it lasts the whole time. We need to be able to realize that. I think COVID augmented that with, do I have enough PPE to keep going back and forth into these rooms as these lines keep failing, or I keep having trouble with these lines? I want to be able to get in, do what I need to do, and get out successfully, right? If I'm worried about an airborne illness, what are the parts and pieces that we need to be successful at this? I can honestly tell everybody that I had the unfortunate instance of being in a hospital during a COVID world. I had to go in for an emergency procedure. I'm a vascular access specialist, right? I've been doing for a long time. Unfortunately, the hospital I was in did not have a vascular access specialist. I was stuck so many times for so many different reasons that I wound up with a septic joint, right? So someone who's a vascular access specialist gets a septic joint, that's not okay. It's not okay for anybody to ever get a complication like that. But if it can happen to me, it can happen to anybody. And I think it just augments the need, right, to raise up that awareness that it's not a commodity. It's not something that we should ever take for granted. It's something that we should be paying attention to, because at the end of the day, we do want that nirvana of one patient, one stick, and it lasts for that one encounter. But I'm going to let Sean weigh in, because Sean has been on the front lines, right, for years, but especially now during COVID. And I think he can share a lot of insights with us on that as well.
Yeah, thanks, Judy. In the experiences that I've seen throughout the hospitals, there's the big push on decreasing PPE and decreasing healthcare worker exposure. It just amplifies the need for the one stick experience. Not only that, there's also a push towards moving to more periphery types of devices because of making sure that devices they have around the neck and, with your IJ central lines, a lot of our patients are now going prone, right? And so collapses are starting to increase throughout I've heard from many different hospitals, based on the fact that healthcare workers may not be in the room as much using video conference calls. And that the fact of the matter is you can't see the dressings as easily. You're not in front of the patients as much. And all of these things, including how they're doing with the tubing, and we're now hanging tubing from the ceilings and the rafters, and in order to be able to limit exposure. All these things are really increasing the need for taking a look at more peripherally inserted devices, and that includes PICC lines, midlines, and IVs. But we really need to be able to make sure that we get in, we do our job, and take care of business so our patients can get the care that they need.
Sean, I'll ask both of you this, and I'd be interested for both Mike and Jill. Jill's been the CEO of a hospital. I wonder if she actually counted the cost of IVs. We'll get to that in a second. I'll be stunned if she actually did. But have you actually seen changes that you think will last past COVID? Are we really changing the way we're thinking about these things? Or is the mindset we're going to get through this now and then go back to the way we did things before? And I would love, candidly, I would love all four of you to weigh in on your perspective of that. What impact does COVID have, and what is the durability of those changes?
So, we're really looking at the long dwell times now on IVs, and we've been doing that actually before the COVID hit with the clinically indicated removal status shift, where now many of the hospitals all over the U.S. have shifted over to, instead of removing IVs on a scheduled 72, 96-hour period, we're now removing them when they're clinically indicated. And so we're trying to keep them in longer. In order to do that, we need to make sure there's many studies out there that are talking about the insertion site and where we're actually placing them. As we move to ultrasound, we're going to be able to choose those sites better. We're going to be able to keep those lines in longer. And so it's not just COVID, this is about care in general. There's many other factors that benefits from ultrasound that, there's dozens of different articles around talking about cost structure, talking about decreased insertion attempts, improving patient satisfaction. There's a couple things that haven't really been documented as well. One of those things is vein preservation. And oftentimes when we're doing these sticks, it's not just the first stick that we're trying to get. This could be the second, third, fourth, fifth stick, depending on how long the stay is. Our patients are in the hospital for longer periods of time. They're getting medications throughout that entire time. We're seeing a higher obesity rate in the nation. We're over 40% now, 26% increase since 26% increase since 2008. Which is a staggering number in terms of trying to get IVs in patients. It's just getting harder and harder. What we call our difficult vascular access patients, that population is just increasing. It seems like it's happening overnight, but I know that you hear stories from patients that's been happening for decades, so they certainly didn't crop out from nowhere. But yeah, there's so many different benefits out there right now. The main reason why the benefit though is when we've been in the hospital and the stories that you guys are sharing, when you're able to walk up to a patient and know that they've been stuck multiple times, which is not a great situation. It's never ideal and it's never good, but to be able to walk up and say, I can help, and be able to get that one stick, and know that you can do it 98, 99% of the time, even after they've been stuck, 8, 9, 10 times. That is something that's incredibly rewarding as a healthcare worker. To be able to offer that service to our patients.
Judy, what's going to stick? He talks about being stuck. What's actually going to stick from COVID?
So I think the status quo has changed, right? I think for a really long time before COVID, it was very mechanical. It was me as a floor nurse going to the storeroom, picking up a straight catheter and trying, right? And when that straight catheter failed, what did I do? I didn't do a root cause analysis even in my head. I ran to the storeroom and I grabbed another one. I think COVID has made us pause and stop to think, hold on a second, is this really the device that I need that's going to last? And my ultimate hope and prayer is that we take the data and we take the learnings from COVID and we put it into action. We make people pause and say, hold on, is this really the device that I need that's going to last for this entire time? I think for a really long time, we've been conditioned to, hey, maybe these central devices are bad because I can't get a CLABSI because a hospital can't take another hit for $45,000. I think with things like remdesivir and these drugs that we really didn't know too much about, and the fact that if I went to just put a straight peripheral in and I had to give somebody remdesivir every day and I was blowing the line every day, it's made us pause and say, hold on a second. The old way I did things doesn't work. I need to stop and figure out what's the best course of action, because at the end of the day, I need this to last. And to your point before, it's not just about device selection. How am I going to take care of that? So it's a 50-50 split in my head. 50% is me picking the right device, right? To make sure that it's going to accommodate whatever I need to infuse into that person for the time I need to infuse it. But it's also, how am I going to take care of that line, right? We know that many central lines, right, have an infection that occurs 74% 4 days after insertion, right? Which leads to the fact that it was the care and maintenance, not the inserter. So for ages and ages and ages, the inserters got a bad rap saying that it was them that wasn't using proper technique.
Not me, not me.
Really, it was
finally validation. Thank you, Judy. Finally,
exactly.
Validation. 30 years later, I finally get it.
Yep. So the evidence shows us that it's not our folks, it's not our inserters that's the problem. It's our folks at the bedside that are the problem, right? And I will say this, right? I'm a nurse. I've been a nurse for 30 years. I started when I was 7. That's why I look so young. But I will say this: a nurse never sets out to do a bad job, right? They're a victim of circumstance. If we don't give them the training and education that they need at the bedside, right? If we don't prepare them for the things that they need to do at the bedside, we're setting them up for failure, right? And not because they want to fail. Nobody wakes up in the morning and says, hey, I'm gonna go give Sean a central line infection today. They just don't know the difference, right? So it's our obligation as hospital CEOs, CNOs, infection preventionists, to make sure that the people at the bedside have what they need and they know how to use it, right? So that we can prevent that 50-50 equation, right? Knowing that they know how to take care of these lines, we can eliminate those lines coming out prematurely, whether they're central lines or they're peripheral lines, right? I need to know how to take care of these lines to make sure, to what you said before, and I'm going to sound like a broken record for the next hour, we want to make sure that one line lasts the whole time. I have to know what to put in, and then I have to know how to take care of it. So I'll get off my soapbox.
we kind of transitioned in so nicely. You guys are so good. You should be on the talk shows. Into kind of the next topic. And I want to flip it to Mike for a second. So these guys are talking really important stuff that I will say sounds almost idealistic to me, that people are actually making that decision. Because I promise you, I'm not sure I've ever seen anyone, whether nurse or doctor, stop for a moment and think, what's the best vein? What's the best catheter? What's the best way to do this? We're a little bit like the historic carpenter that has a hammer. I'm a vascular surgeon. I put in central lines. There's a nurse that puts in peripheral IVs. There's a PIC team. They put in PIC lines. And we have our definitive ways. Mike, have you seen clinically, and then we'll flip to Jill as a president of the hospital, is it really changing the way these guys are saying, or do we have to get them out on a tour around the country to get everybody believing what they believe?
It's a great question, and it's a nuanced discussion. I mean, I think just to add a little color commentary to the end of that last section, COVID forced us to reevaluate a lot of our core assumptions about medicine. As an emergency physician, if you asked me what I should do with a patient who came into the emergency department with an oxygen saturation of 55%, before COVID, I would have said, that's pretty easy. I'm probably going to intubate that patient. And to fundamentally look at people with that degree of hypoxia and realize that the management needed to change, I think it's emblematic of all of the changes that have come in the care of COVID patients. And we've really stopped and had to do almost a care-wide root cause analysis of what's going on with these patients and why are we getting bad outcomes and how do we make it better. And I think we've seen that. And I think that, it's one of the silver linings has been really the medical communities and nursing communities response to COVID is the outcomes are much better now than they were at the beginning when we didn't know very much. We've pivoted really well and adjusted in real time and adapted. The idea that you wouldn't go straight to the the treatment nurse, let's say in the emergency department, the person assigned to that room that the patient's placed into. Traditionally, that person's going to try and start an IV if the patient needs one, which most patients in the ED statistically get an IV. I have seen a shift now where, and I think driven by COVID and the need to limit unnecessary patient contact time, to have the most skilled IV performer go in to place those lines. And in my own department and many departments I've worked previously, those are nurses who are skilled at ultrasound guided vascular access. And they're the ones who typically get called after 2, 3, 4 failed attempts on the patient. And I've seen that shift to let's go get Patrick and have him come in because he can use an ultrasound and we know he's going to get it on the first try. And, it makes you look back at the way you practiced previous to that. And why did the patient have to earn the most skilled operator by suffering through 4 failed attempts when it was pretty clear that those weren't going to be successful? And we, for anybody involved in taking care of these patients in real life, they'll tell you, the last time I came in, they needed to use an ultrasound. They always need to use an ultrasound. I'm a difficult stick. And, we should be going straight to the best possible choice for the patient. In terms of device choice, I'm a little biased on this. I did some research almost 20 years ago, maybe 15 years ago at this point, on placing midlines in difficult IV access emergency department patients to avoid central line placement. And I think that I have seen a shift in the last decade towards much lower frequency of central line placement in the emergency department. We used to do it for really crashing acute patients, and that was really replaced by intraosseous lines. And then for patients, the idea of infusing vasoactive medications through a peripheral IV was really anathema 10 years ago. And now we do it routinely. So, I mean, as much as I'm happy to no longer get pegged as the responsible party for CLABSI and for causing a catheter-associated bloodstream infection, I'm happy that we're not placing as many lines. I think we're being much more thoughtful as a community about what's the right vascular access choice for a given patient, what's their anticipated course, and how do we do it thoughtfully with the patient outcome and patient experience in mind.
Jill, you know, this team has made a very compelling argument about the economics around IVs. And as you and I have talked, both of us have sat on an executive level at institutions, you much higher than I. But I don't remember ever a conversation coming up about the cost of IVs in any of the discussions we've ever had. Did that ever reach your desk? Has it ever been something that you think about? Has that changed today?
No, I would say that never came across my desk. It only came across my desk in terms of hospital-acquired infections, and that's why it did. So, I mean, so that's the larger topic. But I think that just to kind of add on to what everybody has said, COVID has to change how we delivered care prior. And I think because never before had we experienced the risk for healthcare workers exposure ever before in our careers. And I think that as the frontline workers and healthcare workers, as we can be the champions across the universe that can speak to this, and that's the way that care will get changed. And I think there's an incredible thirst now for technologies that can echo what we needed during COVID. And what Mike just said, I mean, the first wave, we had no idea what we were doing, and now we know more, and now we even know more, and we're looking for technologies, whether that's line placement or access to patients' rooms, remote access, but things do have to change. And even just the cost of PPE or the availability of PPE. Again, if these lines are placed correctly and our healthcare frontline workers can go in less, we use less PPE, and the utilization of PPE was one of the most troubling elements of COVID. So I would just say it only got to my desk on a related to infections, but we're all obviously in this room right here, the champions of change after COVID, and it has to happen. So hopefully we can get that message, but I think it has. I think Judy, you put it so well, the pause now is probably something we never did. And now you're never running into a room anymore. And that probably will innately change even a non-COVID patient, that you're not innately running into a room. Because we've had, inter-hospital exposures, patients, even if they're non-COVID. So I love the way you phrased that. I think that really hopefully will make the change.
And I think the onus is on us, right? The onus
Right,
is on us
absolutely.
to take what we learned. We have to take what we learned that COVID taught us and put that into action, right? So the whole situation with COVID, right, has opened up Pandora's box, if you will, to show us the pitfalls, right? So if we never want this to happen again, we need to take what we learned and do something about it. And if that means, investing in the technology to make it easier for us to put lines in, right, to get to the, again, broken record nirvana of one patient, one stick, one hospitalization, then that's what we need to do, right? Because ultimately, I'm saving money. If I invest that money, if I invest that $1 million for that 200-bed hospital that I could be losing, right? And I'm not having that failure rate, well, then I just satisfied the triple aim, if you will, right? So if my triple aim is great outcomes, which hopefully are translating into great patient satisfaction, and I'm not breaking the bank doing it, well, boom, then congratulations to us, because we just achieved that triple aim.
So Judy, you have a unique role. I'm sorry, Jill, go ahead and then I'll jump in.
I'll just briefly add on to that. There's such a thirst for technology and innovation, and I'm just going to add to that process. So we have to make sure that the processes are in place to actually really utilize appropriately the technology and innovation. Everybody wants it. We're going to invest in it, but let's make sure that we're changing how we do things as well.
Exactly.
Yeah, and to that end, this is actually right on point. And Judy, I would love for you to share actually what your role is, because you'll say it better than I ever could. And I think why it's really important. I'm a vascular surgeon at heart, and that's who I am. But I've, if you will, somewhat come over. Some people may say to the dark side, to the industry side. But those of us that make this jump, and obviously Mike and Jill did the same thing, We did so for really important reasons that we knew as individuals we could care for a patient at a time, and there's nothing been more rewarding as a vascular surgeon than to do that. But we also understood the opportunity to impact patients by the thousands, by the millions. You've taken that role as a nurse who's had an incredibly impactful career and now moved across. Can you share with us your role and how you see within your particular company, how you're investing in the same things? I've seen in my career, and I'll just share this, going from industry was the partner, the bad guy, and I think we're swinging back because the real solutions for the future are physicians and hospitals and payers and industry working together to find the right solutions. And I think you represent that really, really well. Can you share with us what you do and then how you see this?
Sure, of course. So I 6 years ago moved over from the bedside into industry. It was a hard decision for me to make, to your point. I struggled with how could I make an impact? Knowing that I made an impact at the bedside, could I still make an impact if I moved over to industry? So I moved over to BD Medical six and a half years ago. And my role is developing customer solutions that really take, it's almost a risk analysis, if you will. So when you work in a hospital, and believe me, I worked there for a long time, right? I was the director of value analysis and supply chain, so I dealt with products all the time. You can develop a very monofocused vision, right? I'm looking within my four walls. I really don't look outside the four walls. It becomes difficult, right, to have a bigger vision. What we've built over the past 6 years is a risk analysis as it relates to vascular access. So being able to come into your facility, look at everything related to vascular access, right? From the emergency room to the NICU, to labor and delivery, to the OR, right? Everything, no stone unturned. Being able to look in all your closets, being able to talk to your clinicians, being able to understand what do they use, why do they use it, and how do they use it, right? Then aligning it to best practice standards. So it's not enough for me to come in and look to see what you're doing and give you my opinion of whether I think it's right or not. That's not what happens. What happens is we align it to best practice, right? So what does the Joint Commission say? OSHA, APIC, SHEA, the Infusion Nurses Society, the Association for Vascular Access. We marry best practice to your actual practice and give you a very robust risk analysis on here's what we looked at, here's where you're doing great, here's where you're not doing so great, and here's how we can help you bridge those gaps, right? Because here's the standard that says what you should be doing. Here's your data that says why you're not meeting that standard, and here's how I'm going to help you bridge the gap, right? So bringing it into this full 360 of being able to call out what's not right, telling you why it has to be right, and then helping you make it right. So it's been incredibly rewarding. It's been a very rewarding scope of work because over the last 6 years, we've taken it globally now, and we've been able to do this in several different countries. We've done thousands of these risk analysis, and the results that we've gotten have been incredible, right? Being able to really see peripheral dwell times increase, be able to see clinicians have better satisfaction with their own jobs and their own roles, being able to really drive those better outcomes has been a very rewarding scope of work for us.
That's awesome. And I think one of the things I love to see is that great clinicians coming into industry makes industry better, and great clinicians inside industry makes healthcare better. And I think you're a great representation of that.
Thank you.
So Sean, part of what you've done and part of the step that you've taken, and I think the next transition is to the next segment here, is about technology. Listen, I sure as heck know, and I started out as a corpsman putting in IVs and prided myself I could be the guy getting tough IVs. But at the end of the day, if you can't see anything, if there's absolutely nothing visible, now what? Well, we've got a now what, and how have you pulled the now what of technology into what you do? And it'll be interesting to see how each of our panelists are now using new technology, how it's going to be useful, and how easy or difficult is it to learn.
Right. So a couple different things. The first thing I want to say is that what we call what you were, or is pulling blood from a turnip, right? You guys can get great. You'll stick them in the thumb. You'll get them wherever you need to go. But those don't necessarily last that long either, right? Depending on what kind of infusions and how long you're going to be able to need it. When you talk about the reality of it, do we really say what's the best vascular access device for the patient? Do we take a big picture look at it? Vascular access specialists, I have to say, they do that. They do take a harder look at it when they actually get those orders in order to make sure that we're going to do vascular access. We do evaluations to make sure that we're looking at the big spectrum on the entire scope of the patient care, and not just that day, not just that stay, but also in the subsequent years and in the patient's lifetime. So the question that I have is that, well, the next thing is that the push now that I've been trying to educate is to have hospitals change their policies from their standard 2 sticks per inserter to, if you can't see it, don't stick, and escalate it up the chain immediately. And so these are some of the pushes that I've seen happening over in the last couple of years. The third thing is that when you don't see anything, right, and you absolutely see that ultrasound is a solution, or you don't have any other solution other than going to something outside of a traditional angiocath insertion, you can train other people. One of the comments is, I have to go to a vascular access specialist, they will do the best job. The push now is saying, how do we stop that from occurring, to how can we go and teach our bedside nurses? How can we teach our bedside personnel, as opposed to just the vascular access teams, to do ultrasound guided IV insertion, to be able to offer vascular access specialist services that was traditionally just for them before, because there isn't enough of us. There isn't enough of the vascular access. I mean, you typically have a handful, small handful for large hospitals. If you have that, if you're lucky enough, there's hospitals that have, 400 or 500 bed hospitals that have one vascular access specialist. And they're never going to be able to reach all of our DIVA patients, our difficult venous access patients. So how do we start bringing this out and allowing it to become more accessible to our bedside inserters? And that's a big question. It's actually a very complex question, because ultrasound guidance is actually a fairly complex program to start successfully. I've been doing it over 6 years. I've been in dozens of hospitals starting programs, and there are many obstacles, many countermeasures that need to be created in order to be able to do this successfully.
So if you look at that, Mike, what are the kind of tips and tricks that using ultrasound? You're an ultrasound educator, you're a master ultrasonographer. What tips or tricks can you give our users that say, okay, I want to start using ultrasound to guide my placement? What can you share?
Yeah, that's a tough thing to teach over a Zoom. I would.
You got 3 minutes to make everybody on this call experts. So how can you do that?
That's not going to happen. But I will speak to Sean's last point a little bit, because I think I think there's a lot of value there, and I think it's worth adding a little bit of external perspective too. So there was a comment to the panelists in the chat from. And I don't know if they want to be named, so I won't name the person who posted it, but from the audience, about having worked at a couple of different level 1 trauma centers with vascular access teams, the problem that they reported is that the lack of availability. A great way to go, but they're not always available due to demand or shortage of employees, and impacts the economics and has to do with failed attempts. And I think that's true. I think that, in a perfect world, your IV is placed by somebody who's just incredibly expert at being a vascular access specialist, but there's a healthcare employee shortage in general. It's orders of magnitude higher for vascular access specialists, and I think that while it is important to recognize that you can't just pick up an ultrasound probe, watch a YouTube video, and be good at placing ultrasound guided peripheral lines. And in fact, I would hazard to guess that doing those 2 things in that order alone as your only training probably makes you more dangerous than helpful. I think that there has been extensive anecdotal experience and a lot of published data on training paramedics, emergency department technicians, nurses, floor nurses, not vascular access specialists, on ultrasound guided peripheral IV access in difficult access patients, not to mention physician assistants, providers, physicians, across the whole spectrum. This is a skill you can learn. What you need to do is you need to be learning from someone who knows how to do it. And you need to understand that there's going to be some deliberate practice involved. This is not a put the probe on the body, stick the needle in the middle of the probe, and wow, you're so good at placing IVs. It takes deliberate practice. And I would say the easiest way to get started to actually answer your question, John, because I was going to get there eventually, is tag along with somebody who does them. That's the best way to get started. If you don't have that resource for you, there's a lot. We've got some online free educational content. There's a lot online that you can look at to get a basic introduction. And then I would practice needle placement in general with an inanimate object. So if you don't have access to a vascular access phantom, a block of tofu works great. If you're not vegan, a pork shoulder works phenomenally. Obviously, and there's a million homegrown recipes that you could just Google online, homemade ultrasound phantom, and you'll find lots of recipes with Metamucil. You can, make, and gelatin, you can make your kitchen a mess and get something to practice just tracking a needle tip under real-time ultrasound guidance. Because the real way that people tend to go wrong here is if you're in the situation where you're placing an IV, hopefully you understand things like site selection. Hopefully you understand things like proper skin preparation and sterile technique. And those are things that are not specific to ultrasound. Those are things just you need to know to be a good placer of a vascular access device. But the nuances of making sure you're looking, let's say you're doing an out of plane technique and you're looking at the needle as sort of a dot on the screen, you need to know if you're looking at the shaft of the needle or the tip of the needle. And if you don't have that skill completely dialed, you're more dangerous with an ultrasound than you are without an ultrasound. So this is not a hard thing to learn. I would push back a little bit on you on that, Sean. I don't think it's hard to learn to place peripheral IVs. Our nurses in the institution where I practice have a program where they train each other. There's a process. They have to get certified. They learn from experts. They get some proctored practice, and then they graduate on their own and start doing their own IVs. It's not a 6-year program. They go through this, and the ones who are motivated within a couple of weeks are up and placing lines, and they're doing way better than they were doing with anatomical sticks in difficult patients. I'm not saying that they're vascular access specialists and they can put in PICC lines and it's a different skill set. But for the bedside nurse or the bedside ER tech or paramedic to get to the point of placing an IV with ultrasound more successfully and safer than they do without ultrasound, it's a learning curve, but it's not. I don't see it as being a prohibitive. This is a skill everyone should get, because then you don't have to worry that you're doing blind sticks on a patient because your vascular access team is busy in the ICU putting in a PICC line, and you're in the ER with a patient who's just suffering. So that would be my take.
So let me throw something in to ask you both, or all three of you actually, or all four of you. And that is, say, this is what I did. I went out and bought tofu. I took a straw, drove the straw through the middle of the tofu and used that to practice. Do you guys recommend, and we're looking for tips and tricks on how people can get better. Do you recommend in plane, out of plane? If you're not being very good at it, what are the things to make you get better faster without it being actually on patients? I love the suggestion of following someone around, but I want people to practice at home. It's a unique feature now that we have handheld ultrasound devices that are affordable, that you own, that you can take home. That's great. But what tricks do you suggest, and I would look for all three of you, on how I can get better faster using my tofu or chicken or something else? And I think a straw works great because it has kind of that same kind of look, if you will, and through tofu, it worked pretty well for me. Sean, you want to throw back and see what you think, and then we'll get Mike and Judy to respond.
Yeah, so I've been teaching this from a formal perspective, 8-hour class type of thing. And by the way, I didn't mean to say that it takes 6 years by any means.
No. He was exaggerating. He was poking.
I know. I'm just teasing. And a push.
We like
also
controversy on our webinars. We like people to actually start throwing things in each other. Virtual shoes go across the screen.
If we're not a little bit uncomfortable, we don't have good conversations.
Yeah,
so that's great.
That's the goal.
Well, so the point that I hope that I was trying to make was that please don't just go out and get a block of tofu and try it and then go think that you're going to be able to be successful with a patient. In fact, most of the articles that you see and the studies you see that talk about in plane versus out of plane, versus talking about different types of techniques, talking about what they needed, they talk about techniques, and they really miss the bigger picture in terms of it's not just the techniques. It's also the fact that what I always say is competency is not equal to, or let me rephrase that, education plus demonstration does not equal competency. So just because you're taught something and just because you can perform it once doesn't mean you're competent. And what I'm really looking for is for an inserter to be able to safely place a line into a patient. And the comment earlier about, yes, we all have put in IVs and we know what sterile technique is, and we know what we need not to be repalpating after sterilization or disinfection. We know those things, but it changes with ultrasound. You now have gel that you need to make sure that you're using a sterile gel in one-time packets. There's so much data around all of this. There's different techniques and there's so many different nuances and different variables that it becomes very, very complex, where it's great to learn from either very skilled clinicians or a standardization in education, which doesn't exist at this point right now. So when I take a look at how would I learn, I think the easiest way to learn is you have to have education first, which is the training. You have to have simulation, which is going to be able to practice those body mechanics and be able to figure out the best ergonomics for yourself, because they're going to differ from person to person. And you need to be able to have simulation, which means on the tofu with the straw or with the Blue Phantom or such. And then you need precepting. You need someone who actually can walk you through this to make sure you're not damaging those veins and think you're actually good. There's a large number of people out there. I hope we can agree on this. Is that there are a lot of people out there who think they're good at this when they really aren't. And how do you track that, right? And how do you consider, in terms of making sure that we're focused on patient safety? These are all really, really big obstacles that have to be overcome. And you need sponsors and hospitals that are going to help you do it. You can't just pick up and start educating and do it on your spare time, because, by the way, you're going to be inserting in patients. So now you got to be on the clock, and there has to be resources in order to pay that inserter to be able to practice. Then you have to put them on shifts where they're allowed to practice. So there's so much sponsorship that needs to be able to provide the resources to be successful in really bringing these programs and helping them become successful. On top of that, you have who are you choosing to teach, right? And your students that are coming in to learn this. They not only have to have the physical, the dexterity and the hand-eye coordination and all that, and the ability to learn, all those kinds of things. But on top of that, they actually have to have a commitment to want to do this. They have to be able to accept new technology. They have to be able to put themselves in an uncomfortable situation, because oftentimes the people who are chosen to do this are really good inserters, and they have to start from ground zero when they do this, because it is very, very different than starting a standard IV. So, picking what I always say is it's not just about competency, it's also about competency and commitment. The inserter has to be committed to learning this, and they have to step down a notch in order to learn how to do it. And not everyone can do that.
Judy, you want to jump in and see what you think? It's interesting. I love your comment about just because you did it once. I think about myself playing golf. I can hit a great golf shot, but it doesn't make me a great golfer. And so it's kind of the analogy that's the same. It keeps me coming back, but it doesn't necessarily make me a great golfer.
Yes.
Go ahead, Judy.
Yeah, no, I think something that Sean hit on was the sponsorship piece, right? And I think that if we go back and talk about, what COVID's taught us, I think COVID's taught us that the status quo is not okay, that we need to sponsor programs like this. We need to invest in our own healthcare system. We need to invest in our healthcare workers. And if that means that we need to stand up a program, right, to have bedside inserters, to teach the bedside nurses how to insert. I just think about the job satisfaction, right? I think if you have a bunch of nurses at the bedside who either don't have a vascular access team, don't have access to the team that exists, right? Because they may have a team that exists, but that team only puts picks in. When at the end of the day, that patient doesn't need a pick, right? That patient just needs a little bit more than I can offer them with my blind eyes, right? Trying to blindly stick. Just think of the job satisfaction that person could have at the bedside if they had the technology and the training and education to be able to insert a longer device or a short peripheral that they could get in at the bedside, right? Just think of the ripple effect that would cause, right? Again, you're going back to, as a healthcare worker, I have better satisfaction. As a patient, I'm having better outcomes and I'm having a better patient experience. And the hospital is experiencing the benefit of that, right? Maybe I'm holding on to my healthcare workers and I don't have this horrible retention problem. Maybe I have better patient satisfaction. They have to be willing to invest in that. And again, it's drilling it down to, do I really care about the $1.50 commodity, what I can consider a commodity item? At the end of the day, we have to raise the bar to say it's not a commodity item. It has a way bigger impact. And are you willing, Mr. CEO, Mr. CFO, to invest in what it's going to take for the organization to change? Because COVID has demonstrated we need to change.
Okay, Miss CEO.
Yeah, exactly.
I knew that was coming. The bullet was lodged toward you. So
right, exactly. No, but
I hope you were getting ready for this answer.
I was getting ready. But
Okay.
just before we even get to that answer, I just want to say, when I trained, we were in the era of see one, do one, teach one. And that didn't necessarily lead to the best outcomes. And I was going to absolutely take off on what you said, Judy, because you started with the triple aim, and it's really the quadruple aim, which really adds our own clinician satisfaction. And it's really been tied, if you have a more engaged, more satisfied staff, frontline staff, that quality improves, outcomes improve. So it's not just the engagement and the satisfaction, it's actually true outcomes have been related to that. And I will also just get back to seeing now and starting to get familiar with the kind of training that Mike does provide, that it's because these devices are portable and accessible and usable, people really can be trained effectively and take it home and do it. So, but I think the investment has to be made. And I think, again, COVID has changed that, but it really does always get back to quality if you engage your staff. And the engagement of that staff, especially now, is probably more important than it ever was.
So let me ask you this question. I'll be a probing one, and you can remain nameless. What institution you were there? Did you guys invest in ultrasound training for your nurses and stuff to actually learn how to do this? Was that something that was a priority for your institutions?
Yeah, it actually was. We actually have someone at the health system who really is a wonderful portable ultrasound trainer, and that really spread from the hospitalists to the ICUs, and not yet to necessarily nurses, but that was the next step. So I often find, and Mike's been there as well, and Sean is at that point also, is when you have a clinical champion that can really say, yes, this makes a difference, and not stop saying it, and really prove the benefits on multiple levels. It really takes that team or that person who champions it to bring it back to administration and said, this is why. And it's probably not one time, but even if you come back multiple times, that does work. But that's why I really do believe in that clinical expert champion that can explain why this is necessary.
So, we've got a lot of people here who are ultrasound believers, and we're not having to convince them to use ultrasound. I'll throw this one out there. What do you guys say is the biggest mistake people make using ultrasound to start IVs? Where is the thing that you see most frequently that you go, okay, that's great, but you should be doing this? Mike, where do you see that? You got a whole team of people who do it. What's the biggest mistake you see? You've educated people all over the globe.
Well, I would say that of the team of people who are well trained up, I have no criticisms. I think they do an outstanding job. We have a vascular access team at our hospital. They also do an outstanding job, and I don't have any. I wouldn't get up on a soapbox and throw stones at any of those folks. In terms of people learning and common pitfalls along the way.
Look at you reframing the question to make sure that everybody feels good. That is,
well, it's not that everybody feels good. It's just, who am I? I mean, I can place an IV into anything, into like an orange, right? I mean, but I've been doing this for 15 years. I got lots of people who are just as good or better. So I don't want to come off like, oh, what mistakes do my teams make? They don't make mistakes. They're great. They make as many mistakes as any human makes. But what mistakes do people make when they're starting off with point of care ultrasound or with ultrasound guided peripheral IV access or even central access? It's the same mistakes. It's not recognizing the need for adjustment to sterile technique. To Sean's point, like you can't use a multi-use gel bottle for an invasive procedure of any kind.
Thank you.
I mean, you need to be using sterile single-use packets of gel. You need to actually take the time to clean the area properly and not just take an alcohol wipe and put an ultrasound probe that doesn't have a probe cover on it to go put in an IV. I mean, there's the reckless sort of just ignorant mistakes, and then there's technique mistakes. There's wrong preset on the device. You're not in a vascular access preset, and now you're not getting that same contrast between the vessel and the surrounding tissues. You're not doing a pre-scan. you don't have a tourniquet on. You want to do a pre-scan and look for clot, look for signs of sclerosis or other, health issues with the vein. Is there a valve right where you're planning on going? These are things that are really easy to assess for, but you need to know to look for them. And that's only the stuff leading up to placing an IV. And there's site selection as well. Do you want to put it, right in somebody's antecubital fossa where it's going to be really uncomfortable? They're going to be begging to have it taken out soon, or in the back of their hand where it's really uncomfortable? Of course not. You're going to look for a site that's not too deep from the skin so that it's got a lower risk of dislodgement, and you're going to look for a site that is comfortable and is going to have a long dwell time for a patient. And then pick the right device. To Judy's point, I mean, I don't place ultrasound guided peripheral IVs with the standard IVs that we stock in our emergency department. We have longer catheters, and I always want that extra segment of catheter within the lumen to ensure that I'm going to have a better dwell time and they're not going to become accidentally dislodged. Am I running out of topics? Not even close. Using an out-of-plane technique when you actually don't know how to use one, using an in-plane technique when you don't know how to use one, starting too far away from the transducer.
What should people start with? Should they start with one or the other?
I think most people, we don't really like talking about our own product on these webinars, which is one of the things I love about them, is they're really educational. And we do have the advantage. This will be maybe one of the only times I mention something that we can do, which is we have the ability to see a needle in both planes in real time with biplane, which is a real potential game changer. That said, I was putting IVs into patients with, 2D ultrasound, not biplane ultrasound, for the last 20 years. And it works just fine if you have good technique. I think most people in a study environment, you may show, and I may even have shown in prior research in my earlier academic career, that an in-plane technique where you go parallel to the ultrasound transducer, you're visualizing the vein, in this case in a long axis, and you see the whole needle tip and shaft coming in, that is more successful. In a tissue phantom, it probably is. In a curved arm on a real human being who may not sit perfectly still for you, it probably isn't. In my experience, I use generally out of plane. So I'll get a short axis view of the vein. Another key error that people make is what I alluded to earlier, which is not sequentially tracking the needle tip into the vein. So it's not like your ultrasound plane is here and you just do that. You need to, your ultrasound plane's here, and as soon as you see your needle tip, you're following it or leading it into the vein. So you know exactly where the tip is at all times. You need to adjust your angle to be able to make sure that you have a smooth insertion of the vein. You don't damage the wall of the vein when you insert the catheter. So these are all things that, I think clearly there's an art to placing ultrasound guided catheters. Whether it's a central catheter, arterial catheter, peripheral IV catheter, you need to, and everything from preparation to site selection, to pre-scanning, to patient selection, to device selection, to technique, all of those things are nuances that in some cases are going to be provider specific. I have a lot of colleagues who like doing both planes, not necessarily biplane, but they like to enter the vessel out of plane and then adjust the probe into a longitudinal axis so they can now see the needle in plane as they're inserting the device. Some people will go back and forth during a procedure. I think, to me, that's a style point. It's like, do you have a two-handed backhand or a one-handed backhand? I'm not here to tell you which way to do that. But I think that you can, the major errors are the simple preparation stuff, sterile technique, site selection, pre-scanning, and then not knowing where your needle tip is. And if, to me, those are like the cardinal sins of placing an ultrasound guided catheter.
Sean, do you have any sins to add to that list, or did Mike hit the nail on the head?
I think you hit the nail on the head, but there's just so many different variables, right? There are other things that you could always include too. I mean, we have certain things that I teach, such as we only move one hand at a time. We never advance the needle when you can still see it on the screen, talking about making sure you're on the tip. Making sure you raise the bed up so it's to a elbow level where you can actually support your weight and support the probe weight on the outside and the medial sides of your hands, so you aren't putting too much pressure on it. Being able to take a look at the orientation of the vein, so you know what angle of approach you need to make, and you aren't setting up to be parallel to the arm, but you're being set up to be parallel to the vein. Traveling up, if you're actually doing a very good job keeping your probe on the needle tip as opposed to the length, then I actually recommend traveling up the vein about extra half centimeter in order to make sure that you fully pierced and punctured the vein. So when you actually advance, you aren't dislodging it immediately. All of these things are really important, and some of these and like I said, we can go on and on and on. It's not a typical thing. And by the way, when you're good at this, it takes a while to learn all these things. If you have a standardized procedure that teaches you this, you can learn it quicker.
Yeah, what I really love about what you both have done here, and actually Judy added it as well, is the nuance of the fact that there's a lot to this. Come on, think about this, and Jill and Mike jump in. When we were medical students, go start the IV. I promise you, when I was a medical student, no one said a word to me about how to start an IV. And as old as you guys think you guys are, I'm older. No one said a word. They just said, go start an IV. And so I'm fumbling through the closet to figure out what I need to get and all that other stuff. And I hate to say that to patients out there listening, but that is the reality. And there is a lot to this. And what you guys have brought to the forefront for us here tonight, which I think is really, really important, is this is an art form. This really is the art of medicine. There are technical aspects of things that are important. There are very specific skill sets that are necessary to get really good at it. And like any other skill, and Sean, you're an example. Mike, your example. Judy, you clearly were in this. That there are Michael Jordans of putting in IVs, and there are those of us that that maybe weren't and played on our high school team, but never were good enough to get past that. Like anything else, there's various skill levels. But like anything else, diligence and practice and really, and I think one of the most important things to learn from what you guys have said is it's not just doing it over and over again. And like you suggested, Sean, you can get it right perfect, but if you didn't really learn from what exactly you did and what was the nuance to it, you're not really going to get better. And I don't want to get past all the nuances of just putting it in and using ultrasound without Judy getting a chance again to re-emphasize, what are you going to put in? I think, Mike, you've done a really good job of bringing to the forefront site preparation, good technique, understanding sterility and why that's really important to have an IV last a long time. But it's also really, really important that's different. I'm not just going to grab a 20 gauge IV angiocath off the cart and just throw it in somebody because I can. And Judy, maybe you can help us before we get to the close here of understanding what are the thought process that go through your head of the decision-making process of what line should I put in? Because candidly, I'm not sure that there's so much attention actually put on that. I think we've learned that having an ultrasound can help. Not everybody needs an ultrasound, but if you're going to use an ultrasound, there's an art form and there's great shared ideas that you shared. What about the catheter? How do I decide which catheter I put in?
So in the clinician's mind, we call it a fishbone, right? So I was taught in nursing school and subsequently to look at things in a fishbone, and maybe I'm showing my age by saying that. But when I think about it in a fishbone, right, I'm thinking about when you think about a fish and all the bones it has, those are all the things that I should be thinking about. I should be thinking about the age of the patient, the mobility of the patient, the cognitive piece of the patient. I should think about the drug. How long do they need it for? Does it have a high or low pH? Does it have a high or low osmolality, right? I should be thinking, there's a whole thought cascade that should be happening in my head before I walk to the storeroom and pick something up, right? So to your question before about pitfalls, you hit it on the head when you said, it's not okay just because I know how to do something that's my go-to, right? And I think in the realm of vascular access, that's what's happened, right? And it happens inherently. I think we know we can go pick this 20 gauge and I can pick, I'll be great at putting it in the AC because I know I can find a nice juicy vein there and it'll be no problem. I'll just put it in 1, 2, 3. Or if I have that ultrasound training, that doesn't mean I get to skip the fishbone. I should be thinking about that fishbone in my head and coming to the end of it and saying to them, okay, is that 20 gauge straight peripheral catheter what this patient really needs? Or should I be thinking about a higher level because at the end of the day, this patient is going to be getting a really caustic medication. They're 86 years old, their vein fragility is pretty bad at this point. They have no skin turgor that's going to support this device. They have no reserves of collagen that's going to hold it in place. I'm going to be precipitating a big disaster if I think that this is the way to go. I need for folks to foster, to just stop for a minute and think before I just go and grab. Because just because I know how to do something doesn't mean I have the right to forego that fishbone exercise.
Hey, John, I want to add a couple of things before you masterfully wrap things up as you do. And first of all, it's a really holistic approach, Judy. I like the way that you put that in it. And obviously, John knows my passion, even beyond point of care ultrasound, is personalized precision medicine, and the right device for the right catheter at the right location at the right time. So just another example. But one thing, everybody thinks they're an above average driver. Right. So you do have to have a way of monitoring what your outcomes are like when you're placing IVs. And I liked, Sean kind of nodded to that earlier, and I really think that's worth reemphasizing. And the other thing is, Sean added some detail that I think would fall under the realm of something I'm really passionate about, which is micro skills. There's a lot of steps in placing an IV, but you can really break, it's a micro skill to find the target vein that you're considering and to pre-scan it to make sure that you're aligned with the axis of that vein. And he alluded to that, but that it isn't hard to learn how to do this. You just need to learn all the steps. It's like if I said to somebody, if I went to my 13-year-old and said, go make me, spaghetti bolognese, he'd have no idea how to do it, and I'm not sure what would come out. But if I outlined steps, first you're going to chop this, then you're going to fry that, then you're going to do it. He could follow instructions. And people who are new to point of care ultrasound for vascular access, you just need to break it down like a recipe so that they're learning each one of the micro skills. Get some time to have someone to spend with someone who knows how to cook already, and to teach you some nuances. And this is really this is a skill that I think if you don't already, as somebody as an audience member, have, but you have a device and you're involved in the care of patients who have vascular access devices placed, it's doable. It just needs to be broken down. And I'm going to make a promise today that a future webinar, maybe even the one that we're planning for early April, that dates aren't released yet, I'm going to walk through a lot of these micro skills in detail, just to give a little more flavor to people who want a little bit more of a technical approach, as opposed to some more of the bigger issue process, philosophical issues surrounding choice of access and technique. We'll hammer into some of these micro skills and get a little deeper.
So Dr. Sun, that's actually something I've been doing for years now, and I've actually broken it down into 7 different steps. With multiple sub-steps in each. And why I'm so passionate about this is that you can teach people who've never done this before, and people who may not be video game players, who may not be hand-eye, and you can still teach them and they can learn. You can give them an algorithm and it will decrease their learning curve to no end and be successful doing that. So, and then as far as the type of catheter, once you decide that an IV is the correct one, there's literature out there with the Infusion Nurses Society guidelines state that 65% of the catheter needs to be dwelling inside the vein in order to be able to prevent dislodgement. Just being able to access, and just the final note is what you're talking about is what I would say is self-assessment is the cornerstone for your success. And it's going to dictate not only how good you'll get, being able to accurately self-assess how good you are, but it'll also be able to predict how safe you'll be with your patients, on which lines you'll try, which ones you won't, and be able to stay in a safe realm to be able to take care of your patients.
I want to close now because we're over time, but I want to say a couple things. And the first of which is I'm thrilled with this discussion. I know a lot of people want to see demonstration. We're going to be the typical teaser and lead you in to come back with us where Mike and others will actually demonstrate some of this stuff. But I will tell you, as a vascular surgeon whose job it was to do vascular access, I mean, all of you have different roles and stuff, but at the end of the day, a vascular surgeon is the line of last resistance often for vascular access. And I've learned something from all of you tonight. I'll share a quick personal story. I used to think people that used ultrasound were people that didn't know what they were doing. I'm a vascular surgeon. I can hit any blood vessel. Who in the mind would actually need an ultrasound to hit a vein? And I currently have been embarrassed to learn that I was an actual fool and an idiot not to know just how valuable that is. This is an incredibly important skill that we all need to learn. The second thing that's really important is our population is changing. Sean, you brought this up. Obesity is a rising epidemic in this country. People are coming in. IV drug abuse is a rising epidemic in this country. And those two things together make IV access incredibly difficult. We also have rising chronic conditions and they require multiple IVs, so the number of veins available. So the ability to do this differently and better is important. I think the statistics that both Judy and Sean and Mike and Jill all resounded here was how important it is both clinically, from a patient's perspective, from satisfaction, and economically it is to get this right the first time, is so important and so underappreciated by the vast majority of people in medicine, that our goal here is actually to change that dynamic. And I'm happy to see the people here actually are vested in actually changing that. And finally, I think the most important point here is this is a skill you got to practice. This is not innately something that you're going to get right away. There's a lot to learn here. There's a lot of nuance to skill here. Practice matters. Mentors matter. Learning and evolving your skills here are critically important in how you're going to get better at this. And so I'm grateful to all our panelists for being part of this. We have the view from Judy, who's moved into industry, from Sean, who teaches people across the country, from Jill, who sat in the CEO's chair, never learned about the price of an IV, but now she knows just how important it was, but made really important decisions for her system to actually invest in education and in training, which is great. And from Mike, who's still living it day to day in the emergency room and training great people. I'm honored to be in your company this evening. I'm thrilled to see that you're still part of changing medicine together. And I hope all of you out there learned something tonight. Please stay with us at Butterfly. We're committed to the education and to the advance of a medicine together. Stay tuned for future webinars that will go into more details and skills on this. Mike will certainly share that with you. And we look forward also to your feedback on what programs you would like to see and hear about, where we can learn together in advancing the care of medicine. Technology is an important part of the contribution of where medicine is going, but the combination of technology and the human element of what we do, and to how important it is that those two things together is what's going to make the difference to the patients that we take care of. And after all, that's why we actually got into this, all of us. So thank you all, and good night.